and welcome back to HealthWatch. Today we're going to talk about irritable bowel syndrome, and as our guest we have a gastroenterologist, Dr. Mehul J. Welcome to our show.
Thank you.
This whole topic of irritable bowel syndrome, I think, is pretty common in our society, and I thought it's a great topic to talk about, but one I think that's sometimes misconstrued, and I think it'd be nice to talk about the definition. You know, what do you consider a person that has irritable bowel syndrome? How do you define it?
Sure, it's a very common condition. I think some of the things that we should talk about is, you know, how many people actually have the condition, and you know, the data indicates that about 15% of the population has the condition. Only about half of those actually go to a physician to get evaluated. And irritable bowel is a syndrome, and it can be difficult to really figure out if you really have irritable bowel. But typically people with irritable bowel have a component of belly pain, which is usually crampy, comes and goes, is what we call intermittent. They can either have diarrhea or constipation, or the combination of two. And the way we define constipation is less than 3 bowel movements a day. That's a very common question that we get. How do you define constipation? And the meaning is different to different people, but as physicians and gastroenterologists, the definition we use is less than 3 bowel movements a week.
3 bowels a week, okay. And how about the diarrheal state associated with it?
Well, the diarrhea can be fluctuating. You can have multiple bowel movements in a day. You can have several bowel movements per week. Once again, you know, diarrhea is defined differently depending on who you ask. The way we look at diarrhea is frequent loose stools that really have no rhyme or reason to it. So that's how we define diarrhea.
Right. Can it? I mean, is it intermittent? In fact, you can have normal bowel movement for months on end and then develop a 3 or 4 month history, or how does it work? Or do you always have the symptom?
Well, there's, you know, irritable bowel is very interesting that it can present really at any age, but most commonly it presents at a younger age. Typically teenagers is when it presents. There is also a form of irritable bowel that often happens after an infection, so that's what we call a post-infectious irritable bowel syndrome. So typically a person has a gastroenteritis, a typical gastroenteritis, whether it's bacterial or viral. They get over that, and afterwards they developed irritable bowel syndrome. So
really?
That's a very common scenario.
And is it because there's changes? We're going to be talking about some of the diagnostic things, but there actually must be changes occurring in the bowel mucosa itself. Yeah.
Well, there's a lot more questions and answers about irritable bowel. We know it's a very common condition, but what we don't understand about it is why some people get it and other people do not get it. We do know that it is more common in people that have anxiety, depression, other medical conditions such as that. But we do know that also that the nerves that supply the colon are more sensitive to changes in environment, stress, anxiety, those kind of things, in people with irritable bowel than those that don't have irritable bowel.
Yeah, I mean, you know, kind of my common knowledge of the bowel itself is it does, one of its functions is absorb the water from the fecal material, and the transient time through that bowel, I guess, affects how loose or how concise that bowel movement is.
Right. So, I mean, in people that have typically the diarrhea predominant form of the irritable bowel syndrome, they typically get spasms of the colon, but when you actually look inside the colon or take tissue samples of the colon, there's really no abnormalities that are seen under a microscope.
Really? So that's, you know, we're going to be talking about that later on, because one of the things is how do you differentiate them from more serious diseases? Not that this isn't serious. And you know, you talked about the seriousness of it and some of the aspects, and I think it's interesting to know, but this can be a life-changing disease for some people. Yeah. And certainly, and as you say, it's pretty common.
Yeah, it's very common. You know, it's much more common in women than men. We say the ratio is 2 to 3 to 1, for as common in women to men, and it is a very time-consuming problem. It is a very serious problem in a lot of people, but one of the most important things to realize is that if you have irritable bowel, it doesn't put you at increased risk of developing other conditions such as cancer of the bowel.
Yeah, that's one of the other questions I'm sure you get very commonly is that if I have this, you know, what am I more likely to have?
Right.
Yeah, you talked about, some of the, we're going to be talking about therapies later on. We talk about the instance of nervousness or psychological issues, because we all have had that. I mean, certainly a stress phenomena, and next thing you know, you're loose stool. So the nerve innervation and the way it affects your bowels is common to all of us. Yeah. It just seems to be a hypersensitivity in people that have this condition.
Yeah, that's very true. It is a hypersensitivity, and people that are able to control the stress aspect of things or the anxiety aspect of things, their gastroenterology symptoms seem to be better. And that's one of the things and that is one of the treatments for irritable bowel syndrome, is to treat the underlying anxiety or stress associated with it.
Yeah. Easy to say, tough to do sometimes.
Very tough to do.
Talk about I guess my naive view of this was always supposed to be it was more of a diarrheal symptoms, but people can in fact present more with the other aspect of a constipation. I hadn't thought of that as irritable bowel syndrome, but how often do you see that as part of the complex?
Yeah, that's very common. Most people that we see, come in with a diarrheal aspect of things. But the constipation is just as common, and there are people that come to see us because they've had diarrhea all their lives, and then all of a sudden it changes to constipation. So that's the third subset of people that have the syndrome. There's one set that have the diarrhea predominant, there's another subset that have the constipation predominant, and then there's a third subset that alternate, between the two.
Right. How can you differentiate, and I know from experience that some people can relate that to food ingestion. Gee, if I eat that, I'm going to be in the toilet for the next 3 weeks. Yeah. How often, and I imagine as a gastroenterologist, sometimes it's tough to know, is it associated with allergies, food allergies?
Sure. Yeah, that's a very common question that we get, and it's very difficult, because if you take 100 people with irritable bowel and you give 50 of them onions, half of those people would say they have problems, the others would say they would not have problems with it. So what I typically do is actually have my patients make a food diary and see if there are certain foods that seem to trigger the symptoms. We do recommend in general for most people, whether they have the diarrhea predominant or constipation predominant, is to increase their fiber intake, and that often helps regulate their stools. The other things that are often helpful is a low lactose or low dairy diet. That's often very helpful too.
Okay. Well, we're going to take a break and come back, and I'm anxious to hear, because many of these people come to they're self-medicating, like you say, over-the-counter medications and the like, and we can speak to some of that. Yeah. Then others going to their family doctor being treated. By the time they get to you, it's the more serious cases and how you in fact handle that. So. And welcome back to HealthWatch. We've been talking to Dr. Lalani about the irritable bowel syndrome, a very common problem, and one that at times I'm sure we have all either family members or friends that have had this problem. Talk to me a little bit about some of the over-the-counter treatments. I mean, most people kind of know to self-medicate themselves as well, and now you can get kind of low modal and some of the others motility issues over the counter. Is there a danger to doing that, or is it something that you would recommend?
Well, I would say that you really need to see a doctor and make sure that you don't have any other more serious conditions that can be associated with diarrhea or constipation. And it's not a diagnosis that's easy to make, but a lot of times we get referrals from family doctors who've been made the diagnosis already, and we need to rule out other more serious conditions. And the things to look out for that could indicate a more serious problem is persistent diarrhea that's not getting better, weight loss, blood in the stools, persistent belly pain, having low blood counts just by routine blood testing. Those things should not be occurring if it's just purely irritable bowel. And one of the other things that's a common differentiating factor is having diarrhea that wakes you up out of sleep. If you have that, that usually indicates something more serious than irritable bowel syndrome.
Right, that's interesting. And we talked about, the type of stool without getting more graphic about it, but the mucus in the stool, the blood in the stool, you can still see that with irritable bowel.
Yeah, I mean, mucus is common with irritable bowel. Blood usually indicates something else. It doesn't mean necessarily that you have cancer, but certainly blood in the stools could indicate more serious conditions such as Crohn's disease or ulcerative colitis. Or other even less, serious conditions like hemorrhoids that could be bleeding.
Yeah, just because of the frequency of, of your stool.
Sure.
And like, and I'm sure with at a three stools a week, it would be there was some difficulty passing.
Yeah, I mean but I think the most important thing to do is to see a doctor and make sure that you don't have more serious conditions. Certainly, if you're over 50 and you haven't had a colonoscopy, that would need to be done to make sure there's no other lesions.
So from what I'm gathering, in a younger individual pre-50 who having recurrent symptomatology like that, you would approach them more on a symptom basis, whereas if you're over 50, you're looking more for a differential basis.
Yeah, I mean, over 50, regardless of if you have symptoms of diarrhea or constipation, you do need a colonoscopy. Under 50, it really depends, what your other symptoms are, how serious they are. Do you have any alarming features, as we talked about? Do you have any abnormalities in your blood tests? Do you have low blood counts? And certainly even the younger population, there's other things you need to rule out. And one of the most common conditions that could mimic irritable bowel is called celiac disease, where you actually have an allergy to gluten, which causes diarrhea, nausea, vomiting, belly pain. So it can be tricky sometimes to differentiate the two.
Yeah, that's another show we ought to do on a regular basis, because I think that's another thing. That's probably the more underdiagnosed disease state that we think about, and sometimes with tragic results. So the patient coming to you, and they've already gone over the counter. I've had this my whole life. I've seen my family doctor. It's really, like you say, some of these people are life changing. What can you do to help me? And your differential, you already talked about.
Yeah.
You'll expect to have a blood count done. Your history is what you've stated, and now, and would you? And again, it may, and I would gather you probably do a fair amount of colonoscopies on these people just to make sure there's nothing else in the colon.
Yeah, if you have the typical symptoms, they're long-lasting, you don't have weight loss, the other alarming features, and you're under 50, then you may not do a colonoscopy. But like I said, the other things to check would be celiac disease. There's other conditions that you do a colonoscopy and you actually take tissue samples, and an abnormality comes out, and that's a fancy word called microscopic colitis. But that's another condition that can present with intermittent diarrhea. So you really need to have a complete history physical, some blood tests, and then figure out if more testing is needed. In the younger people, if they've had symptoms all their lives, it's probably not necessary.
Okay.
So,
but when you do a colonoscopy, and I'm interested in hearing that, you would think intuitively there would be a difference that you could tell, but apparently not.
Yeah.
Unless and are you doing biopsies on those people?
Yeah, a lot of times we do biopsies if diarrhea is their predominant symptom. If it's constipation, we don't do typically biopsies. But that's the interesting thing. When you do biopsies in people with irritable bowel syndrome, they come back normal. So.
Yeah, that's I think the take-home message, because I think the other things that you talked about, the differential that you're looking for, are pretty serious disease. Let's just talk about some of those, ulcerative colitis and Crohn's disease. Speak to that a little bit.
Well, they fall in the category of what we call inflammatory bowel disease, and those are really conditions where you have your immune system actually builds up antibodies to parts of the bowel, and in particular the colon in most cases. That is completely different than irritable bowel syndrome, and you typically get blood in the stools. You see what appear to be ulcers of the colon. You take tissue samples, and when they look at it under a microscope, it's abnormal, very abnormal, compared to irritable bowel, which is completely normal.
There's a distinctive look to that bowel.
Yes.
Right.
Yes.
I'll bring in another differential just to kind of be complete, but we talked about in this day of antibiotic use that we see people all the time, people who wouldn't normally have diarrheal states, who take antibiotics and suddenly develop diarrhea. It's always a source of concern. You as a gastroenterologist, just speak to that a little bit.
Yeah. Well, that's a very common syndrome, is to get diarrhea after antibiotics. Most commonly is the antibiotic itself causes the diarrhea, but there's another condition that's very common that a lot of people probably have heard about called C. diff. That's a bacteria that particularly happens after antibiotic use. And that is, once again, completely different than irritable bowel syndrome.
Yeah, something I think but you also can do doing a colonoscopy, you can tell that difference as well.
Yes, yes.
Really?
Yeah.
The other disease states you talked about, the kind of the, I'm alarmed about, am I more prone to cancer and the like. These people still could have polyps, they may still have it, but there is no higher incidence of those disease states in people with irritable bowel as opposed to others. That's what the take-home message?
Yeah, that's a very common concern, and we get that question all the time, since I have irritable bowel syndrome, am I more likely to get polyps of the colon or colon cancer? And the answer to that is no. Your life expectancy is just as good as anybody else, and you're not at higher risk of developing any more serious lesions.
Right. There's another disease entity we see more commonly in the older age group, and I'll just, for completeness, but it's these small outpocketings, so-called diverticular disease, which is not uncommon in the older age group patients. Yeah. Is there a higher incidence in people who in fact have had that history of having had an irritable bowel over their lifespan and now developing that?
Yeah, those two are not really associated, irritable bowel and diverticular disease. And what typically happens, and we think happens, is over time there becomes kind of a weakness in the lining of the bowel. So you get these pockets called diverticulosis. If those pockets get infected with bacteria, then that condition is called diverticulitis, and that's where typically people get very severe pain associated with it. We do think that people that have constipation are more likely to get diverticular disease in general, but there isn't a direct correlation between irritable bowel syndrome and diverticular disease.
Okay, good. And welcome back to HealthWatch. We've been talking about the irritable bowel syndrome with Dr. Lalani, and I guess when we left, we talked about some of the things that can develop, pluses and minuses of what we've been looking at. But I think the practical thing we need to talk about is if you have this, and like you say, 15% of the population have at various degrees, are there effective therapies? What can we do about it?
Yeah, I think the therapies are really dependent on what your symptom is that's predominant. So if you have diarrhea, typically we use over-the-counter medications such as Imodium or Lamodal, those kind of medications that slow the diarrhea down. If you have constipation, one of the first treatments we use is to increase fiber in your diet to see if we can increase your bowel movements. It's someone that has had constipation their whole lives. It's not really practical to think that they're going to have a bowel movement every day. So that's one thing to realize, is that everybody's bowel history is different than one another. Having one bowel movement a day is not normal for everybody. So we typically give medications that can increase the frequency of bowel movements, but as we talked about, the goal in a lot of these people is to at least have more than 3 a week.
Right.
There's other agents that are over the counter. One of the most common agents used right now for constipation is Miralax, and that's a powder you mix in with water. That can be used once or twice a day, and that works in a lot of people. Once you get past that, then you start thinking about prescription medications, which are a little bit stronger, and there's a whole list of medications that are used. The other symptom of irritable bowel that we get use medications for is the belly pain. That's usually crampy. It can come and go. We use spasm medicines for that. The two most common are Levsin and Bentyl, and those are used very commonly. One form of Levsin is actually you put it under the tongue. It works very quickly for belly pain and relieves the spasm and cramping aspect of things. Once you get past that and you have symptoms that are going on despite taking those things, then we get into a different class of medications. We usually use medications that were traditionally used for depression. But the doses that we use in the medications are much lower than what they use for depression, and it's more for pain modulation is what we use them for.
Yeah. Yeah, it's kind of interesting, not to get too technical, but I remember one of the drugs that came out was talking about the serotonin, which we know is a factor in depression and some of the others, and actually the same type of chemical in the brain is also present in the bowel, and it made some sense to treat it that way when you think about it, because you're talking about mortalities. But and maybe you could speak to that, because I know the drug came out for a while and now it's been taken off. But has there been more work done on that? Because that makes enormous sense to me. Because if that's the problem, why not treat the problem?
Yeah. Well, some of the antidepressants are, the fancy word is serotonin SSIs is what they're called, and they're still used for depression at higher doses, but at lower doses they're used for irritable bowel syndrome. There's been a few medications that have been recently taken off the market that were used for irritable bowel syndrome. One was for the diarrhea predominant form of irritable bowel syndrome. That was called Lotrinex, and that was taken off the market because people were having low blood flow to their bowels, which is a fancy word called ischemic colitis. Another one that they used for the form of irritable bowel that's a constipation predominant was called Zelnorm, and that was a very common medication, and that was taken off because of cardiac problems. So there's a lot of ongoing research about irritable bowel because it's one of the most common types of patients that we see in our office, and one of the most common type of patients that even family doctors see in their offices. So there's really a lot of research going on about the topic.
I guess that's one of my, it seems I've known about in all my practice lifetime, and not uncommon family members that have, and yet all these years we know kind of what the issue is, but we've yet been able to attack that cause. Because everything you described is symptomatic treatment, basically, without really attacking the underlying cause. And I know these new drugs have been attempts to do that, but like everything else, it has problems.
Yeah, we really, that's one of the issues with irritable bowels. We don't know why certain people get it and other people don't get it. But we really haven't been able to figure out what is the underlying cause of irritable bowel syndrome.
Yeah, I was kind of interested in hearing you talk about infectious etiologies as potential, because sometimes, and I know even my own family members come back and say, I had strep, I was on penicillin, I had problems with penicillin, I got diarrheal states, I've had it ever since. So that going back to that causative factor, and it's not common to everyone, but it is a factor.
Yeah, that's a common story we hear. They have some type of infection. Usually it's a gastroenteritis. They developed irritable bowel syndrome, and then they have it off and on for a long time afterwards. It's also interesting in one of the newer treatments for irritable bowel syndrome is what are called probiotics. So there is, we think, a mechanism where there's less good bacteria in the bowel than there should be, and if you add some good bacteria called probiotics, which are present in some of the newer yogurts and those kind of things, it helps symptoms of irritable bowel syndrome.
Right. Do you find if you have a patient who has had that a relative serious case of irritable bowel syndrome and they need to be on antibiotics for whatever, an ear infection or whatever, is there a value putting them right on probiotics at the same time? Because I know that's been done.
Some people do that. I don't think there's any good data to support that unless their irritable bowel symptoms really get worse when they're placed on antibiotics, then there may be a role in that, but it's not something that's done on a routine basis.
Right. It's such a pervasive issue, and I know it's a life-threatening. Are there groups, societies that are available now, support groups for this as well?
Sure. Yeah. There's a lot of support groups available for irritable bowel syndrome. The other things that really is helpful is really stress management. I don't think we can underemphasize that. It's really dealing with other conditions that could be contributing to your gastroenterology symptoms. So stress management is in counseling, and the general things that we recommend, making sure that you do things that you really enjoy, exercise, those kind of things to relieve stress, and once people do that, their GI symptoms really improve significantly.
Yeah, I think it's a good take-home message. Do you ever recommend anti-anxiety medications for these people as well? I mean, not that we want to dope up anybody, but it makes some sense when you think about it.
Yeah, I mean, my personal practice is to try to counsel them in terms of stress management and try to use as little medicine as possible. But there are a subset of people that need medications, and they don't do well unless they're on medication. So yeah, we do prescribe anxiety medications when we have to.
Yeah, I can imagine, and it's almost like a family counseling thing. Again, I've had family members that have had this problem, and it does sometimes involve the family. Where's the nearest bathroom? Which can be quite disturbing, or I'm afraid to go on a trip. Or I was going to be a great singer, but I could never do that and stand up in front of an audience. Yeah,
I think that is one thing that this is can be a serious disease, and we get that question often: is what should I do when I travel? You know, and if you think about it, your diet changes when you travel.
Sure.
Stress changes because you don't know. You know, with the airline industry right now, you don't know if things are going to be on time or not on time, and you know, those kind of things.
We have to wrap it, but yeah, I lived through that. All right, thanks for coming, Dr. Lalani. I appreciate your information, and thank you for watching HealthWatch.